Good afternoon, everyone. Today, I'll be discussing the approach to a case of exudative retinal detachment with leopard spots with the help of a very interesting case and dilemmas we dealt with along with the queries which still remain unanswered. There are no financial disclosure. So the patient is a 63-year-old male, known case of type 2 diabetes mellitus, dyslipidemia and hypertension since past 12 years under treatment. He presented with complaints of gradual onset, painless and progressive diminution of vision since 4 years in both the eyes, the left eye followed by right. There was previously documented history of subretinal fluid and pigment epithelial detachment in both the eyes along with the exudative retinal detachment in left eye. There was a history of undergoing 4 intravitreal anti-VEGF injection in left eye and 2 in right eye over the period of 4 years. His best corrected visual acuity in right eye was 360 and in left eye was 6.9. The anterior segment was within normal limit. He was pseudophakic in both the eyes. The posterior segment showed the photos were taken by a handheld fundus camera. In the sitting posture, the patient shows an inferiorly elevated retina, and in the supine posture, he had a shifting of the subretinal fluid, which shows almost a subtotal retinal detachment. In the left eye, the retina was attached when he presented to us, but there was a documented detachment in the left eye previously, which settled on its own. And on we did an FFA to rule out any leakages in case of a multifocal CSCR, but we found pigmentary hypertrophy and RPA hypertrophy and a leopard spot retina in both the eyes. The OCT in the right eye was corresponding to the retinal detachment, and it was done in obviously sitting position. And so he underwent a battery of investigation to rule out all the possible causes. The blood investigations, the routine CBC, ESR were normal, within normal limit. The chest X-ray was within normal limit. He also complained of minor difficulty in passing urine, so he underwent a KUB USG which showed a grade 2 prostatomegaly. Then he underwent a prostatic specific antigen which was high at the level of 10.19 nanogram per ml. So we suspected that it's probably a metastasis, and he also underwent a PET scan to see if there are any hyperreflectivity. So in PET scan he showed features which are suggestive of primary prostatic neoplasm with nodal involvement. So he was referred to a surgeon where he underwent a TRUS biopsy, but he showed no neoplastic growth on histopathological report, and it was found to be an incidental age-related change. He also underwent an MRI to see the scleral thickness, which was 1.5 mm in right eye and 1.2 mm in left eye, which was in normal range. The USG-B scan in right eye showed a retinal detachment, and the UBM showed a choroidal detachment. In the left eye, there was just choroidal thickening with normal retina attached. So the dilemmas were, when the patient presented to us, he already underwent a few intravitreal injections. So the presentation was modified when he presented to us. Secondly, there was documented subretinal detachment and a PED earlier, which responded to an anti-VEGF. The evidence of chronic retinal pigmentary epithelial changes in the left eye was also there. So our first differential was the chronic CSCR of an atypical variant. The next finding of choroidal detachment on UBM and B scan was found. The scleral thickness was again within normal limit on MRI as well as on UBM. So we shifted our diagnosis to the uveal effusion syndrome. Although the axial length was normal, so we thought it's probably the type 3 variant of uveal effusion syndrome, where the axial length is normal and the sclera thickness is also within normal limits. But we detected a prostatic mass. So our diagnosis again shifted to a metastasis or a paraneoplastic response, and we evaluated him fully for a month with a battery of investigation. Meanwhile, we also gave a therapeutic trial of an anti-VEGF for a pachychoroid or a chronic CSCR spectrum. But no response to anti-VEGF was found, and the prostatic mass detected was also found to be benign. So again, we moved back to the uveal effusion syndrome, but we thought to rule out lymphoma, which was very less likely, but we still thought of doing a ab externo drainage along with subretinal fluid analysis. But during the procedure, there was an induction of an iatrogenic break, and we had to convert the procedure to a PPV with drainage of subretinal fluid and endolaser. Luckily, it worked, and this is the post-operative photograph of the patient after 4 weeks, and his vision improved to 660. He's still under follow-up, and there are no active detachment as of now in either of the eye. So the issues that we still are thinking about was that a pachychoroid with exudation? If yes, then why was there a choroidal detachment? And he also didn't respond to the anti-VEGF we gave. Finally, we came to the exclusion, we came to the diagnosis by exclusion of uveal effusion syndrome type 3, which is a non-anophthalmic eye with normal scleral thickness. Thank you. Lastly, I would like to acknowledge my professor, Dr. H.S. Trehan, for his inputs and support. Thank you.